Hello, doctors. We're going to read today the nephrotic syndrome guidelines, which is very important guidelines in your practice and in your exams as well. It comes up very often in the video, in a history as well. So let's start reading together. We will stress on the very important points, and I may skip some points unnecessarily to save our time. Okay, so let's start. First of all, how we know this patient has a kind of nephrotic syndrome. So first of all, he will be having edema, hypoalbuminemia, to plasma albumin. Plasma albumin will be less than 25 gram per liter. Heavy proteinuria, which is 3 plus dipstick or more. Urinary protein more than 40 milligram per square meter per hour. Early morning protein creatinine ratio more than 200 milligram per millimole, and hypercholesterolemia as well. So these are the main features of nephrotic syndrome: edema, hypoalbuminemia, plasma albumin less than 25 gram per liter, heavy proteinuria, 3 plus on dipstick, urine protein more than 40 milligram per square meter per hour, the early morning protein creatinine ratio more than 200 milligram per millimole, and hypercholesterolemia. What are the symptoms and signs? So the first thing, it's edema. He's gonna be oedematous and swollen, mainly periorbital around his eyes, pedal, in his feet, sacral and scrotal edema, also ascites or pleural effusion. The cardiovascular can be difficult to assess due to edema, to assess carefully for hypovolemia. So how we can know that this patient has hypovolemia? The child with diarrhea and vomiting and looks unwell, abdominal pain strongly suggestive, poor peripheral perfusion and capillary fill more than 2 sec, pulse character 3D, low volume, difficult to palpate, tachycardia or upward trend in pulse rate. Hypertension may be an early sign, hypotension a late sign. Jugular venous pressure will be low. So all these will guide you and direct you and warn you that this child have a hypovolemia and he's going to be shocked. Okay, so muffled heart sound suggests a pericardial effusion, serious complication of nephrotic syndrome. So that's very important points to keep in mind. The difficulty in breathing, pericardial effusion, pleural effusion, hypertension first sign, and hypotension the late sign, the tachycardia, the low GVB pressure, abdominal pain, the capillary fill will be more than 2 sec, the 3D pulse, all these would direct you. Okay, what about the respiratory? It's going to be tachypnea and recession, suggest pleural effusion. The abdomen swelling and shifting dullness suggested ascites, tenderness with fever, umbilical flare, suggest peritonitis, scrotal edema, stretching can cause ulceration or infection. Okay, so what the investigation we're gonna do in here? Femoral blood sample is contraindicated because of risk of thrombosis, so never think about femoral blood sampling if you are suspecting a nephrotic syndrome for first time diagnosis. So basically, we will start with urine investigations, which is urine analysis, early morning urine protein creatinine ratio, first morning after admission, normal value less than 20 milligram per millimole, in nephrotic range more than 200 milligram per millimole, usually up peak to more than 600 milligram per millimole. Low urine sodium, it's going to be a low fraction, less than 10 millimole, suggest hypovolemia. Okay, so that's the basic, the first thing to have to do, your analysis, early morning protein creatinine ratio, and low urine sodium. We have the baseline bloods, urea and electrolytes, and creatinine, albumin, full blood count, immunoglobulin IgG, A and M, complement C3 and C4, zoster immune status, hepatitis B and C serology as well. These are your basic blood. So that's again your electrolyte, creatinine, albumin, full blood count, IgG, A and M, complement C3 and C4, zoster immune status, and hepatitis B and C. The second line test is going to be only requested if features suggestive of more aggressive nephritis. So if the patient have hypertension, macroscopic hematuria, high creatinine level, and no response to corticosteroids, you have to shift to the second line investigations. Second line investigations, which is you will ask for the anti-streptolysin O titr and anti-DNase B, anti-nuclear antibodies, and anti-double-stranded DNA, anti-double-stranded antibodies. So these are the second line tests you will ask for. And how you're going to interpret the results. So if you have found any high hematocrit, this suggests a hypovolemia. Raised creatinine or urea suggests hypovolemia, tubular blooding, or other nephritis. Serum cholesterol and triglycerides often elevated, IgG usually low, C3 normal. Okay, so what's your differential diagnosis in here? You could think of minimal change disease, which is 95%, focal segmental glomerular sclerosis, multi-system disorder, such as Henoch-Schönlein purpura, SLE, diabetes mellitus, congenital nephrotic syndrome, very rare and seen in under 2 years, congenital nephrotic syndrome. Okay, so this is your differential you could think of. What's your immediate treatment? So generally, first of all, if you are suspecting a nephrotic syndrome, you have to admit strict fluid balance monitoring, daily weigh mandatory. You weigh him every single day, avoid added salt, but a low salt diet not indicated. Manage hypovolemia, seek senior advice before volume resuscitation as a risk of volume overload. So you will inform the nephrologist with you in here. You cannot manage by yourself, and you have to seek advice from your senior before you start volume resuscitation. Fluid restriction in nephrotic syndrome, restrict to insensible losses. For example, 300 ml per square meter plus urine output. If not tolerated, aim for 600 ml per day in children aged less than 5 years, 100 ml per day from 5 to 10, and 1000 ml per day more than 10 years. Again, you will consult your senior before doing that, and you have to be careful with fluid resuscitation. What about the medication? The medication in here, it's prednisolone 60 milligram per square meter oral once daily in the morning. Phenoxymethyl which is penicillin V for pneumococcal prophylaxis. So you start steroids and antibiotic hand by hand. If liquid formulation required, you can use amoxicillin. If edema upsetting to patient or causing discomfort, add furosemide 1 to 2 milligram per kg orally. I'm not sure about this, guys. I have prepared the edema and shock management guidelines from the website itself. I prepared over here. That's regarding the albumin infusion. Okay, whether he was shocked, he was mild hypovolemic or severe oedematous. So this is from the website. It's I got it from the NHS University Hospital of Leicester, which is going to be reviewed in 2024. Okay, so this is the most recent update. Okay, so regarding the albumin infusion is only indicated in symptomatic hypovolemia or severe diuretic resistant edema. It should be administered with a great caution with frequent monitoring of vital signs until at least 2 hours after infusion is completed. Okay, so on here, if we have the patient, shocked patient, so if he in shock, okay, you will start 4.5% albumin 20 ml per kg over 30 to 60 minutes, repeated if necessary. You can repeat it again. If volume status remains depleted, discuss with regional pediatric intensive care before giving further boluses. Okay, so that's the shocked patient. If the patient has a mild hypovolemia plus edema, you will give 20% albumin, 5 ml per kg over 5 hours because it's very, very concentrated. So it takes long time for the infusion. It's over 4 hours. It's unlike the 4.5% albumin. It's going to be over 30 to 60 minutes. Okay. So in here, you will give IV furosemide halfway and at the end of the infusion. So keep this in mind. Provided signs of hypovolemia have resolved, mid and end point clinical evaluation should be carried out. Okay, if we have severe diuretic resistant edema, you have tried everything, but unfortunately, this edema is still resistant. It's not going to be improved. So you will give 20% albumin, 5 ml per kg over 4 hours again with IV furosemide halfway through infusion. Okay, ensure that your individual hospital transfusion policy will allow for infusion of 20% albumin over that will be more than 3 hours, not less, okay? Unless there is experience in giving 20% albumin and facilitate for high dependency monitoring, consideration should be given to discussion with a pediatric nephrologist with view to transfer to that's the place where they transfer the such cases to Nottingham or more local critical care bed. So this is the piece of information that I have added on this part of the management of edema in the Green Book. I have replaced it because I'm not sure about this. I'm not sure. It's not clear for me in here in this book. It's not clear for me how to manage edema. It's very clear from this guideline. Okay. Okay. So the important thing that you have to keep in mind as well, as you are starting a high dose prednisolone in daily basis, you will give omeprazole for gastroprotection whilst on a high dose of oral steroids. It's very crucial to mention as well. So high dose steroids, 60 milligram per square meter per day, with penicillin V with omeprazole. Okay, use omeprazole granules or lansoprazole, dispersible for patients with intral tubes. Okay. The complications of nephrotic syndrome, doctors, is very important. We have to know everything about it and how you manage every single complication. So the most important one, it's the hypovolemia. It may present with abdominal pain, vomiting, looks unwell, tachycardia, poor perfusion, high hemoglobin. So you will seek advice from your senior before volume resuscitation in here, as risk of volume overload. You will give sodium chloride 10 ml per kg. It's not 20 in here. It's restricted fluid. Start the dipyridamole. Do not confuse 4.5% albumin with 20%, as the latter is hyperosmolar and can easily cause intravascular fluid overload. Okay. The other sign for the hypovolemia, as we have mentioned before, that's low GVB, raising urine creatinine, and poor response to diuretics. The treatment, you have to check with your consultant first. You will not start any medication by yourself. Salt, poor, hyperosmolar albumin, 20%. 20%, that's 0.5 to 1 gram per kg. Again, the doses should be checked from the BNF again. No one can memorize any doses. With furosemide, midway infusion over 10 minutes. Okay, so that's the management of hypovolemia. Regular observations for signs of circulatory overload. You have to check the GVB from time to time, tachycardia, gallop rhythm. He may develop heart failure if he got volume overload, breathlessness, and low SpO2. Often required daily liaise with specialist center as well to manage the patient. So that's the hypovolemia. We have spoken about it in the whether he's shocked with edema only, mild hypovolemia. We know all this stuff now. What if he got peritonitis, which is difficult to recognize? Steroids he's taking may mask these signs, including fever or cause leukocytosis. Mainly, it will present with abdominal pain, consider hypovolemia and appendicitis as well. Request early surgical opinion, obtain blood culture and peritoneal fluid, 4 grams stain and culture. If possible, then start piperacillin with tazobactam. So that's piperacillin and tazobactam, which is called Tazocin IV bending culture result. So you will start immediately Tazocin and you will wait for the culture result, and then you can change your antibiotic accordingly. If penicillin allergic, discuss with microbiologist or consultant in infectious disease. So if the patient has allergy to the penicillin, so you will not go to choose any other alternative antibiotic. You have to discuss with the microbiologist in here first. It's not your choice to change to any other antibiotic. Cellulitis as well, commonly caused by hemolytic streptococci and pneumococci. So you will treat promptly for cellulitis. Thrombosis is very common with nephrotic syndrome to have thrombosis. The very common type of thrombosis is renal vein thrombosis, an important differential in abdominal pain, renal vein thrombosis, peritonitis, hypovolemia. We have cerebral vasculature, sagittal sinus thrombosis is very common with the nephrotic syndrome. They will develop headache. So keep all these red flags in your mind. Pulmonary vein thrombosis as well may cause pulmonary infarction. Femoral blood sampling contraindicated. That's why never ever think to have a blood sample from the femoral because you will predispose for a femoral thrombosis. A fall in platelets, raise in D dimer, and reduced PTT are suggestive of high risk of thrombosis. Ultrasound scan with Doppler study to look for perfusion and to image renal vein, and IVC can be helpful. If in any doubt, seek advice from pediatric nephrologists regarding the investigations and management. All right, so in thrombosis, we have renal vein thrombosis, sagittal sinus thrombosis, pulmonary vein, femoral vein, low platelet, high D dimer, low PTT. You need to do Doppler study to check the perfusion in the for renal vein and the IVC as well. You will consult the pediatric nephrologist in all this with you. You would not work by yourself. What about the discharge policy and subsequent management for nephrotic patients? Discharge once in remission. If he start to improving, the protein level start to be low in urine, defined as a trace or negative urine protein for 3 days. Patients with normal blood pressure and stable weight who are well may be allowed home on ward leave with consultant approval. Normally twice weekly review will be required until in remission. So you will review him twice a week. It's not just discharging him home and you never know about him. So you have to review him 2 times a week, arrange plan of care with patient and carers, outpatient review in 4 weeks' time. Okay, for the new patients, newly diagnosed with nephrotic syndrome, they will discharge on prednisolone 60 milligram per square meter, as we have mentioned before, once daily for 4 to 6 weeks. Then 40 milligram per square meter, alternate days for 4 to 6 weeks. Gradually reduce doses, aiming to stop after 3 to 4 weeks. Response usually apparent in 7 to 10 days. No response after 4 weeks. Daily steroids, 60 milligram per square meter, suggest steroid resistant nephrotic syndrome. Okay, so that's very crystal clear for us. What's about the relapsing patients? How we can know this patient he is having a relapse? 3 consecutive days of 3 plus or more early morning proteinuria, having previously been in remission, and then they got relapse. Start prednisolone 60 milligrams square meter once daily, continue until nil or trace proteinuria for 3 days, then 40 milligrams per square meter, the same regime on alternate days for further 4 weeks. Gradually reduce dose, aiming to stop after 3 weeks. If relapse is frequent, despite alternate day prednisolone, discuss with the pediatric nephrologist. So if this patient keep relapsing every time, it's like on off, then you have to refer him to the nephrologist to have a look and do more further investigations for him. Oral prednisolone. While on prednisolone, 60 milligram per square meter once daily, advised to carry a corticosteroid card. It's very important to mention. he definitely will have a steroid card, a bracelet, seek appropriate medical attention for illness, especially zoster contact, if not zoster immune. Other management, urine testing, teach technique and provide appropriate dipsticks, test only first urine sample of the day, keep a daily proteinuria diary and bring it to every clinic attendance. So the diary is very, very, very important for nephrotic syndrome, for proteinuria diary, corticosteroid diary with instructions regarding corticosteroid dosage, as well the corticosteroid diary as well is crucial in here. We have to mention and keep in mind. The next page is talking about infection precaution. So the nephrotic patients are very vulnerable people. You know, it's very challenging to keep themselves healthy and to avoid infections. So they have to avoid live immunizations for 3 months after completion of treatment with high dose corticosteroids. Benefit of inactivated vaccines can be impaired by high dose corticosteroids, and so a similar delay advisable where possible. Where not possible because of frequent relapse, give inactivated vaccine after a shorter delay and check for an antibody response. Continue phenoxy, methylpenicillin, penicillin V, prophylaxis until edema has resolved. If penicillin allergic, give azithromycin. So if he is allergic to penicillin, previously they mentioned we have to consult the microbiologist, and here they mention you can give azithromycin instead. If liquid formulation required, you will use amoxicillin. If exposure to chickenpox and zoster non-immune and immunoglobulin negative and on high dose steroids, give IM zoster immunoglobulin, as we have mentioned before. After definite zoster contact, a contact is infectious 2 days before onset of rash until all lesions crusted over. So 2 days before the onset of rash and until all the lesions crusted over, can be given up to 10 days after exposure. About the zoster immunoglobulin, we can give it up to 10 days after exposure. That's okay. Contact consultant microbiologist on duty as well. You have to involve him with you for release of for zoster immunoglobulin. At first sign of illness, give acyclovir IV, varicella vaccine, varicella vaccine, which is live vaccine available and should be given if a suitable opportunity arises between relapses. So we can give him varicella vaccine, but in a remission period. He is not in relapse, he is stable, he is in a remission. He can get the varicella vaccine in between relapses. Give pneumococcal vaccine if child hasn't received pneumococcal conjugate vaccine as well. You have to check the BNF in here. They are in the block letters in here. So it's crucial to check your BNF. Do not try to memorize doses. Indications for referral to pediatric nephrologist. So these are things, if happened, you have to refer to the nephrologist immediately. If we got corticosteroid resistant diseases, corticosteroid dependent, if there's steroid toxicity, if there's mixed nephrotic picture, if age less than 1 year or more than 12, if there's low C3 and C4, and if there's ANA positive. So all these indications to refer to the pediatric nephrologist. Okay. So this is the end of our nephrotic syndrome guidelines for today, doctors. I wish you enjoy this guideline. I tried my best to make it quick and brief, and we focused only the important points. Please like and subscribe for more videos and guideline, and for this channel to keep going. And please leave me a comment down below if you have any comments to share with me. I will be happy to read and interact with you as well. Thank you.